You know that nagging gut feeling? Maybe it's a persistent ache or sudden urgency or just this general discomfort that, well, it just won't quit. It's surprisingly common, actually, and often really isolating. So if you've ever wondered what's really going on when your gut doesn't feel right, or maybe you're supporting someone who deals with this deep dive is for you. Today, we're unpacking irritable bowel syndrome, IBS. We're working from a pretty comprehensive set of notes aimed at, demystifying this condition.
Yeah, and it's fascinating, isn't it? Because IBS is so common, but there are still so many misconceptions floating around. And for a lot of people, there's this quiet frustration, maybe even a bit of shame attached to it. So our mission today is really to cut through some of that noise. We want to explore what the science actually says, helping you understand not just what IBS is, but maybe why it causes such distress, how doctors recognize it, and crucially, what can actually be done to manage it. Because there are things that help.
Okay, great. So let's start right at the beginning. What is IBS fundamentally? Our sources call it a common, chronic, functional gastrointestinal disorder. That word functional, I feel, is really key here. It suggests the problem isn't something you can, see. Not obvious damage, but something about how the gut works. Can you unpack that a bit?
Absolutely. That word functional is, well, it's central to understanding IBS. For people with IBS, the issue isn't usually something like inflammation or ulcers that a doctor could see on a scope or a scan. Instead, it's more about a profound miscommunication, you could say, between the gut and the brain. This gut-brain axis we hear about gets dysregulated.
Okay, gut-brain axis, miscommunication.
Exactly. So the core problem involves things like abnormal gut motility. That's how food and waste move through your system, too fast, too slow, or just erratically. And another huge factor is something called visceral hypersensitivity.
Visceral hypersensitivity. Okay, that sounds intense. What does that actually feel like for someone?
Yeah, it basically means the nerves in the gut are overly sensitive. Think of it like your gut's internal alarm system being set way, way too high. So normal things like gas moving through or the stretching from stool passing things that wouldn't bother someone without IBS suddenly trigger significant pain or discomfort.
Wow, like the volume knob is just cranked way up on normal sensations.
That's a great way to put it. And alongside that, we also see alterations in the gut microbiome, the bacteria living in the gut, and even the immune system playing a role, too. It's a really complex picture.
So the challenge for patients, and I guess for doctors, too, must be huge. The pain is absolutely real, but there's nothing physically broken to point to. Given that sort of invisible nature, how widespread is this? Is it common everywhere?
You've hit on a key point. That invisible nature, it definitely compounds the difficulty and frustration. And yes, it's incredibly common. Our sources estimate it affects somewhere between 10 to 15% of the global population.
10 to 15%, that's huge.
It really is. A massive number of people navigating these challenges, often silently. And interestingly, the sources do point out it's more frequently diagnosed in women than in men. The reasons for that disparity are still being explored, but it's a consistent finding.
Okay, so it affects a lot of people, often women more than men. But it sounds like IBS isn't just one single thing. Our notes suggest there are actually different ways it shows up, different patterns. That seems really important for how you'd approach it, right?
Exactly right. It's not monolithic. Thinking of IBS as a single condition is, well, it's not quite accurate. It's more like a spectrum. And recognizing these different subtypes, which are mainly guided by the Rome 5E criteria looking at stool patterns, that's really the fundamental starting point for finding relief that actually works for the individual.
Rome 5E criteria. Okay, so what are these main types?
So the main ones are, first, you've got IBS with constipation, or IBS-C. That's where hard or lumpy stools happen at least a quarter of the time, and loose or watery stools are pretty rare, less than a quarter of the time.
Okay, C for constipation. Makes sense.
Then there's IBS with diarrhea, or IBS-D, basically the opposite pattern. Loose or watery stools at least 25% of the time, and hard or lumpy ones are uncommon.
D for diarrhea. Got it.
Then you have IBS with mixed bowel habits, or IBS-M. This is where people experience both significant amounts of hard, lumpy stools and loose, watery stools. Each type happens at least 25% of the time. It's that back and forth pattern.
Right, the alternating type. That sounds particularly tricky to manage.
It can be. And finally, there's IBS unclassified, or IBS-U. This is for folks whose symptoms don't quite fit neatly into the C, D, or M categories based on those stool consistency criteria. But understanding these main patterns, C, D, or M, is really crucial because it directly guides doctors on tailoring the treatment approach.
That makes a lot of sense. Knowing the pattern helps you target the problem.
Okay.
So we see how it manifests differently. But the big question for so many people is, why? Why does this happen? Our sources are clear. It's not one single thing, but this complex mix. What do we know about the underlying causes?
Yeah, the why is definitely the million-dollar question. And it is multifactorial. We don't have one single smoking gun. But, as we touched on, a primary player is that gut-brain axis dysregulation, that communication highway between the brain and gut. It's got static bad signals.
Like crossed wires.
Sort of, yeah.
Yeah.
And that faulty connection can cause chaos. It might make the gut speed up way too much, leading to diarrhea, like an IBS-D, or might slow things right down, causing constipation, like an IBS-C. So that directly links back to those subtypes we just talked about.
Okay, so the gut-brain connection is central. What else?
Then you have that visceral hypersensitivity we mentioned, those supersensitive nerves reacting strongly to normal stuff. And that often goes hand in hand with altered gut motility, basically, irregular spasms or contractions of the muscles in the intestine walls. They're not contracting smoothly or rhythmically.
Right. Now, one thing in our sources really caught my eye about causes. This idea of post-infectious IBS. It sounds like a bad stomach bug, like gastroenteritis, can actually trigger this chronic condition in some people. How does that happen?
It's a really important point, actually. A significant number of IBS cases do start after a severe bout of gastroenteritis, a nasty bacterial or viral infection. What seems to happen is that the gut's immune system gets ramped up during the infection, and sometimes it doesn't fully settle back down afterwards. There might be lingering low-grade inflammation or subtle changes to the gut lining, or the nervous system itself might remain hypersensitive. It's like the gut remembers that initial insult.
Wow. So an acute event leads to a chronic problem.
Exactly. And another big area of research is changes in the gut microbiome, that community of bacteria living in your gut. An imbalance there, sometimes called dysbiosis, is increasingly thought to contribute to IBS symptoms for some people.
And then there are food triggers, right? So many people with IBS point to specific foods. Our sources mention food intolerances, particularly things like poorly absorbed carbohydrates, the famous FODM packs.
Yes, FODMAPs. That's an acronym for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. These are types of carbs that aren't well absorbed in the small intestine and then get fermented by bacteria in the large intestine, producing gas and drawing in water. For someone with a sensitive gut, that can trigger pain, bloating, and diarrhea. Things like lactose intolerance or even non-celiac gluten sensitivity can also be factors for some individuals.
Okay, so FODMPs, lactose, maybe gluten. And what about stress? We hear a lot about stress in gut health.
A crucial point. Our sources are clear. Psychological factors like stress, anxiety, and depression do not cause IBS. Let's be really clear on that. But they can significantly exacerbate symptoms. It's that powerful feedback loop through the gut-brain axis again. Stress impacts the gut, and gut symptoms impact stress levels.
A vicious cycle.
It really can be. And finally, there might be genetic predisposition. IBS does tend to run in families, suggesting some people might just inherit a susceptibility.
Okay, so a whole range of potential factors. Gut-brain axis, sensitivity, motility, infections, microbes, food, stress, maybe genetics. It's complex. With all that going on underneath, what are the actual signs and symptoms someone might experience day to day? Our sources say they can vary a lot and come in flares.
Yes, flares is a very common term. Symptoms can definitely wax and wane, which can be incredibly disruptive and unpredictable.
So what's on the list? I mean, the common things people report.
Well, top of the list is usually abdominal pain or cramping. The key thing here is that it's often, though not always, related to bowel movements. Sometimes it gets better after going, sometimes worse. Then, of course, those altered bowel habits, the classic diarrhea, constipation, or that frustrating pattern of alternating between the two.
Right, the C, D, or M we talked about.
Exactly. Bloating and abdominal distension are also really common, that feeling of uncomfortable fullness, pressure, and sometimes you can actually see your abdomen swell up. And related to that, often excessive gas or flatulence.
Okay. Pain, altered habits, bloating, gas. What else?
The notes also mention changes in stool appearance. This can be quite specific. Mucus in the stools is common. In IBS-C, you might see those hard, pellet-like stools, sometimes described like rabbit droppings. In IBS-D, it's typically loose, watery stools.
And that feeling of urgency.
Yes, urgency. That sudden, intense need to find a bathroom right now is particularly common with IBS-D. And lastly, many people report a feeling of incomplete evacuation, like you haven't fully emptied your bowels even after you've just been. This is lingering discomfort.
That list really paints a picture of the daily struggle this can be.
It really does. And, for many listening, that might sound very familiar. Now, when it comes to getting a diagnosis, what's often frustrating is that there's no single definitive test for IBS. No blood test or scan that says, yes, you have IBS.
So how do doctors figure it out then?
It largely relies on a careful assessment of your symptoms, looking for those characteristic patterns we discussed, and crucially, ruling out other conditions that could be causing similar symptoms. The main diagnostic guide used is the Rome Theta criteria. Essentially, doctors look for recurrent abdominal pain happening, on average, at least 1 day a week in the last 3 months. And that pain needs to be associated with 2 or more of the following. It's related to having a bowel movement, it's linked to a change in how often you have a bowel movement, or it's linked to a change in the form or appearance of your stool.
So it's about the pattern of symptoms over time, not just a one-off bad week.
Exactly. It's about establishing that chronic pattern. This involves a detailed medical history, talking through symptoms, diet, stress, family history, and a physical exam.
But what if there are signs that maybe it's not IBS or something more serious is going on? Our sources mention red flag symptoms. Why are those so important to identify?
That's a critical distinction. Because while IBS is uncomfortable and disruptive, it doesn't cause long-term damage or lead to more serious diseases. But other conditions can. So, red flag symptoms are warning signs that need further investigation to rule out other possibilities. These include things like symptoms starting after age 50, any unintentional weight loss, rectal bleeding or blood in the stool, persistent fever, or unexplained iron deficiency anemia.
Okay, so new onset later in life, weight loss, bleeding.
Right. Also, a family history of conditions like inflammatory bowel disease, Crohn's, or ulcerative colitis or colon cancer. And another one is nocturnal symptoms, symptoms that actually wake you up from sleep. IBS pain usually doesn't do that. Finding these red flags is crucial because it prompts doctors to look deeper to be sure they're not missing something like IBD, celiac disease, infections, or even cancer, though that's much less common.
So if those red flags appear, what kind of tests might someone expect?
To rule out other conditions, a doctor might order various tests. Blood tests are common, like a complete blood count, CBC, to check for anemia, inflammatory markers like CRP, and tests for celiac disease. Stool tests can check for infections or blood, and importantly for a marker called calprotectin, which can help differentiate IBS from IBD, as it's usually high in IBD but normal in IBS. Sometimes a hydrogen breath test might be used, maybe to look for SIBO, small intestinal bacterial overgrowth, or lactose intolerance. And then more invasive tests like a colonoscopy or sigmoidoscopy might be recommended, but usually only if those red flags are present, or for routine screening in people over, say, 45 or 50.
Okay, so once other things are ruled out and the diagnosis points strongly to IBS based on symptoms and history, the focus shifts. It's about managing it, right? Our sources emphasize it's not usually about a cure, but more about managing symptoms with a multimodal approach. Sounds like building a personalized toolkit.
Precisely. That's a great way to think about it, a personalized toolkit. And often, the first line of defense, the foundation really, involves dietary modifications. Probably the most scientifically supported dietary approach for IBS is the low FODMP diet.
Right, we mentioned FODMAPs earlier as potential triggers. How does this diet work?
So it's a temporary elimination diet. You significantly reduce foods high in those fermentable carbs, the FODMAPs, for a period, typically a few weeks. The goal is to see if symptoms improve. If they do, you then systematically reintroduce different FODMA groups one by one in small amounts. This helps you identify which specific FODMAPs are your personal triggers and how much you can tolerate. It's really crucial, though, that this is done with guidance from a registered dietitian or a knowledgeable healthcare provider. It's quite complex and restrictive, and it's not meant to be a forever diet.
Okay, so elimination, then careful reintroduction. What about fiber? That seems counterintuitive sometimes. Can it help or hurt?
Good question. Fiber is interesting. Soluble fiber, the kind found in things like psyllium husk, oats, and some fruits, often helps both constipation and diarrhea. It forms a gel, can bulk up stool in diarrhea, and soften it in constipation. Insoluble fiber, however, like wheat bran or raw vegetable skins, can sometimes worsen symptoms like bloating, gas, and pain for some people with IBS. So it's often about finding the right type and amount of fiber, which might take some trial and error. Soluble fiber is usually the better starting point.
Makes sense. And beyond specific types of food, what about just general eating habits?
Yes, regular meal patterns seem to help avoiding skipping meals or eating very large meals. And of course, identifying and avoiding specific trigger foods that you notice consistently cause problems. Common culprits beyond FODMAPs often include caffeine, alcohol, spicy foods, high-fat meals, and sometimes artificial sweeteners. Keeping a food and symptom diary can be really helpful here.
I can imagine people listening thinking, oh, great, I have to give up coffee and eat spicy food. It sounds like a lot to navigate.
It can feel overwhelming, which
Yeah.
is again why professional guidance is so helpful. It's about finding your specific triggers, not necessarily restricting everything forever.
Okay, diet is huge. What else is in the toolkit? Lifestyle.
Absolutely. Lifestyle modifications are critical, especially stress management. Given that powerful gut-brain connection, finding ways to manage stress is key. Techniques like cognitive behavioral therapy, CBT, can help change thought patterns related to symptoms. Gut-directed hypnotherapy has surprisingly strong evidence specifically for IBS. It helps calm that gut-brain communication. Mindfulness, meditation, yoga, even just deep breathing exercises can all make a difference. And don't underestimate regular physical exercise. It's good for stress, and it can help regulate bowel motility too.
So diet, stress management, exercise. If those aren't quite enough, then medications come into play.
Yes, pharmacological therapy or medications are another important pillar, used when needed to target specific symptoms. For instance, antispasmodics like hyoscine or dicyclomine can help relieve abdominal pain and cramping by relaxing the smooth muscles in the gut wall. For IBS-D, antidiarrheals like loperamide can be used usually on an as-needed basis to slow things down. For IBS-C, various laxatives can help, like polyethylene glycol, PEG, but sometimes doctors prefer specific prescription medications for IBS-C, like linaclotide or plecanatide, which work differently by increasing fluid in the intestines.
Are there specific meds just for IBS-D too?
Yes, there are medications like aloxetiline or rifaximin, which is an antibiotic sometimes used for IBS-D, thought to be related to gut bacteria changes that target specific mechanisms involved in IBS-D.
Okay. Now, the one that might surprise people is antidepressants. Our sources mention them. You clarified earlier they're not always for depression itself in this context.
Exactly. It's a common point of confusion. But low doses of certain antidepressants, particularly tricyclic antidepressants, TCAs, or sometimes SSRIs, are used frequently in IBS management. They're used primarily for their pain-modulating effects. They can actually alter how pain signals from the gut are processed by the brain, effectively turning down that volume knob we talked about. They can also help regulate gut motility. So it's about targeting the nerve sensitivity and function, not necessarily treating underlying depression, though they can help if mood issues are also present.
That makes more sense. And probiotics. Lots of buzz around those.
Probiotics are interesting. The evidence is still a bit mixed and seems to be strain-specific. Some strains, like Bifidobacterium infantis 35624, have shown some promise in studies for reducing overall IBS symptoms, particularly bloating and gas. But it's not a guaranteed fix, and finding the right probiotic might take some trial and error. It's definitely worth discussing with your doctor.
We've covered so much ground: what IBS is, why it happens, how it's diagnosed, and this whole toolkit for management. As we wrap up, what's the big picture? The long-term outlook?
Well, the key message from our sources is that IBS is a chronic condition. It's generally something that needs long-term management, not a quick fix. Symptoms will likely fluctuate. There will be bitter periods, maybe even remission, and then periods of flare-ups. Learning to navigate those fluctuations is part of the journey.
But importantly, what about the scary stuff? Does it lead to worse things down the line?
That's probably the most crucial reassurance we can offer, based on the sources. IBS, despite being disruptive and uncomfortable, does not cause permanent damage to the intestines. It absolutely does not lead to inflammatory bowel disease like Crohn's or ulcerative colitis, and it does not increase your risk of developing colorectal cancer. Knowing that can lift a huge weight off people's shoulders. It separates the discomfort of IBS from the danger associated with other conditions.
That is incredibly important to emphasize. So it really boils down to that personalized approach, doesn't it? Finding your combination of strategies, the diet tweaks, the stress tools, maybe medications working closely with your healthcare provider. Our notes also mention the value of patient education, really understanding the condition, and even support groups, connecting with others who get it.
Absolutely. Empowerment through knowledge and shared experience is huge. And perhaps as we finish this deep dive, here's a final thought to consider, something provocative maybe. Knowing just how profoundly IBS is shaped by this intricate gut-brain connection. How might a deeper understanding of that axis transform how we approach not just IBS, but maybe other chronic conditions that seem rooted in similar kinds of systemic dysregulation?
That's a really powerful question. It makes you think about how interconnected everything is: mind, gut, body. Hopefully, this deep dive into our sources has given you a clearer, more informed view on IBS. Whether it's for yourself or someone you care about, we hope it helps navigate the challenges with a bit more clarity and maybe confidence.